The topic rare dyslipidemia, if you introspect properly, then it is very heartening and poignant, as nothing about rare. Hello, hello. Why is not as nothing.
Yeah, it is.
About rare disease is simple, not the diagnosis, not the daily care, not the long-term cure. The disease may be rare, but the suffering is universal and banal. So, what is a rare disease as per se? A rare disease is health condition of a particularly low prevalence that affect a small number of people compared with other prevalent diseases in the general population. The average global prevalence, if you say, have a threshold for a rare disease, is estimated to be around 40 to 50 cases per lakh people. India, like many other developing countries, currently has no standard definition of rare disease and data on prevalence. And since there is no epidemiological data, there are no there is no there are no figures of burden of rare diseases and morbidity and mortality associated with them. So I pledge here in this conclave and platform, whosoever is listening to my pledge, as I am unable to see you all, that we must at least start a registry of a rare dyslipidemia from very beginning. European Atherosclerotic Society Task Force aims to address the uncertainty of the diagnosis, management, and access to treatment of rare dyslipidemia by theoretical background to underlying pathophysiology and practical clinical guidance. Although genetic testing has a clear role in definitive diagnosis, it is always a predominant phenotypic expression and clinical features that determines the course of clinical management. So it is very important from the very outset the patient enters into your clinic that the diagnosis starts, and once it is suspected, then only you can go with a genetic testing to just cleanse the diagnosis of rare diseases. First, you have to suspect it. So I would like to briefly describe the lipid metabolism pathway that is focusing on causal factors that to understand the pathophysiology of rare dyslipidemia. I will take only 2 to 3 minutes in a nutshell to just recapitulate the very difficult biochemistry which is inherent in to understand this rare dyslipidemias. And in the very outset, in the intestine, the apolipoprotein B containing lipoproteins are produced by intestine, ApoB48, and in the liver, ApoB100. Endogenous dietary fatty acids and sterols are actively absorbed and immediately resecreted by ABCG5 and ABCGGH. So what happens once it is it never internalized finally when exogenous dietary proteins and endogenous lipids are packaged into lipoprotein precursor by microsomal TG triglyceride transfer protein, and it requires SAR1B. Once chylomicron enters the circulation, where the triglyceride content is hydrolyzed by LPL, that is lipoprotein lipase, resulting in the delivery of fatty acid to local tissues. And this LPL needs some stabilization, secretion, its promotion and inhibition. How this happens? It is a beautiful feedback control mechanism by one LMF, that is lipase maturation factor 1, is required for secretion of LPL, whereas GP1, HBB1, that is glycosyl phosphatidylinositol anchored HDL binding protein 1, which stabilizes LPL at the endothelial surface, and ApoC2 and ApoC5 promotes LPL activity whereas ApoC3 and ANGPLT3 inhibits LPL activity. So the remodeled small lipoprotein remnants are cleared by receptor-mediated mechanism involving ApoE that we can see here. That liver is where it is cleared. Finally, what is the this is basically exogenous pathway of the liver. The endogenous pathway, that's the ApoC2. The circulated PG-rich VLDL undergoes similar LPL-mediated hydrolysis, forming small IDL, which further is processed by hepatic lipase to L-cholesterol-rich LDL that delivers cholesterol to peripheral tissues, and some LDL catabolized by the hepatic LDL receptors. ApoB100 containing receptor binding domain are responsible for ligand of LDL receptors. LDL and LDL receptor complex is internalized and translates through a very well-characterized pathway required for LDL receptor associated protein. LDL contents are degraded in lysosome by LIPA, that is lysosomal acid lipase. The deficiency or mutation of this LIPA gene may cause cholesterol storage diseases, suppressing intracellular cholesterol synthesis and stimulating esterification. So this is basically the whole LDL chylomicron system. Now we will just briefly in 2 lines the reverse cholesterol transport system, which is here. You can see that apolipoprotein A1 produced by liver and intestine constitutes primary protein of HDL particle. And ABCA1 ubiquitously expressed and effluxes phosphatidylcholine and unesterified cholesterol from plasma membrane to lipid poor ApoA1 and pre-beta 1 HDL or small HDL. What happens then? This pre-beta HDL transforms to small discoid particle that is a target of LCAT, which is activated by ApoA1 which uses phosphatidylcholine and unesterified cholesterol and as a substrate and generates cholesterol ester. So once LCAT derived cholesterol esters is transferred by sept to VLDL and LDL or directly to the liver via scavenger receptors. This is, in a nutshell, is a causal focus and is a lipid metabolism which focuses on the causal factor in rare dyslipidemias. We will slowly and gradually come to different slides to understand the mutations of rare dyslipidemias. Thus, we can see that around 25 monogenic dyslipidemias are defined. Monogenic is generally a rare, and polygenic is common. So we will only point out the rare disorders that defined by extreme biochemical deviation with or without physical features and typically follow pattern of autosomal dominant, codominant, or recessive inheritance. We know, it has been absolutely spoiled. Now, this LDL related disorder, if you see that, LDL, now we go with the different types of lipid disorder. Like first, it is functionally we will divide into LDL cholesterol related disorder, like high LDL cholesterol related disorder, low cholesterol related disorder, then triglyceride, then high and low, and then HDL, there's a low and high. So if we go with a LDL related disorder, this ApoB containing lipoproteins comprise LDL, IDL, VLDL, and chylomicrons and their remnant particle, and the lipoprotein A. All are proatherogenic and play a key role in transport of cholesterol and triglyceride in the circulation. This particle represents the historical, if you remember, there's a pre-beta lipoprotein electrophoretic mobility classes. So if you see that we are going to discuss now in a very brief. There's a high LDL cholesterol related disorder. That is, the defining feature is increased LDL cholesterol and ApoB100, lipoprotein, apolipoprotein B100. So that results from impaired interaction between LDL particles and its receptor, in which the core defect is delayed clearance of LDL cholesterol. So these are the genes which are involved in high HDL cholesterol related disorder, like LDL receptor gene, ApoB, PCSK9, that is gain in function, PCSK9, LDL receptor associated protein, ABCG5, ABCG8, that is steatosterolemia, apoin, and LIPA. So what is the basic approach of this patient? Once this patient comes with a around young boy of around less than 10 years of age, having physical signs of arcus cornealis, xanthelisma, tendon xanthomas, and if in untreated premature cardiovascular disease, however, once the blood cholesterol and lipid, once it is seen that it is more than 400 if it is untreated, and more than 300 if it is treated. So this is, if it is there, then we have to first rule out, we have to rule out the secondary causes like nephrotic syndrome, primary biliary cirrhosis, untreated hypothyroidism, anorexia, or in other medication. And if it all fulfills the criteria, then we go directly for the next generation DNA sequencing. Once, if it is, if we see that there is a biallelic LDL receptor, ApoB, PCSK9, or LDL receptor associated protein mutations, that comprises of homozygous familial hypercholesterolemia. The management would be, management would just build upon the heterozygous familial hypercholesterolemia that are well established and involve the combination of maximally tolerated statins, ezetimibe, and PCSK9 inhibitor, in addition to diet and lifestyle. So sometimes, PCSK inhibitor is helpful in some cases, but it is not helpful in null mutations of LDL receptors. So, there are investigational therapies like LDL receptor gene therapy, ANGPTL3 inhibitors, and rarely there is a liver transplantation. But one thing we have to understand that for homozygous familial hypercholesterolemia, lipoprotein apheresis is the foundation, given the severity of LDL cholesterol that is increases profound atherosclerotic risk and refractoriness to other treatment. To go to the steatosterolemia, that is mutation in biallelic ABCG5 and ABCG8, the drug of choice would be the ezetimibe. And finally, that a LIPA mutation, where it is a very rare, it is only 20 to 25 patients already have, we have seen 20 to 25 patients all over the world that have, that is a therapy, is replacement therapy with sebalipase alpha. Now coming to am I audible? Am I audible?
Yes, yes, sir. Yes, sir. Audible.
I'm audible? Okay.
Yes, sir.
Okay. So I can't see anybody now, so it is very difficult. It's absolutely in the way. So if LDL cholesterol, now we will discuss low LDL cholesterol related disorders. There's a primary beta lipoproteinemia, which refers to a group of inherited dyslipidemia characterized by very low or absent LDL cholesterol and apolipoprotein B concentration. The gene which is involved is NTTP, ApoB, SAR1B, ANGPTL3, and PCSK9. So it's very important because the A beta lipoproteinemia, this is one of the dreaded disorders, Clinical manifestation is like acanthosis with mild anemia with birth, fat malabsorption, growth failure in early childhood, later onset of features of fat-soluble vitamin deficiency, including night blindness, atypical retinitis pigmentosa, osteomalacia recurrens, posterior column signs, spinocerebellar ataxia, increased prothrombin times. So with this feature, with the boy, which comes with this feature, first we have to rule the secondary causes, then the clinical assessment which we have done, and then we have to go with a certain tests, and finally we have to go with a newer next generation DNA sequencing. We have there are 3 or 4 points which we have to understand. First, there's a benign condition, that is biallelic ANGPLT3 mutation and biallelic PCSK3 mutation, which happens. Here it is seen that there's a benign condition and the patient rather are protected from ASCVD, atherosclerotic cardiovascular disease. So there's a therapy. So from this point of understanding, we have a therapeutic strategies for PCSK, anti-PCSK antibody and ANGPLT3 antibody, because it rather protects from the wrath of ASCVD. But here, just conversely, that the A-beta lipoproteinemia is a dreaded disease, homozygous familial lipoproteinemia, beta lipoproteinemia, and chylomicron retention disease. The therapy is a low-fat diet, high-dose oral fat-soluble vitamins with a medium-chain triglycerides, and frequent monitoring of eyes, neurological variables, and liver. Now we will discuss triglyceride-related disorders. That is, first, we will have a chylomicronemia syndrome, that is hypertriglyceridemia, 1 to 2% of the adult with a severe hypertriglyceridemia have monogenic cause. So monogenic severe hypertriglyceridemia result from completely impaired LPL mediated lipolysis. So there's a complete impairment of LPL activity. So LPL, what are the genes which is involved in LPL? That LPL itself, then ApoC2 and ApoA5, which is a promoter of this gene, and lipase maturation factor 1, which is basically a stabilizer, and GP1, HBB1 is a gene which stabilizes LPL in the endothelial cells. So this is all bombarded, and that is a condition which leads to a severe disease known as monogenic chylomicronemia. And that individual, the phenotype is tend to express hypertriglyceridemia with a younger age, less likely to obese or have a secondary factors, a fasting triglyceride concentration of more than 1800 milligram per deciliter, higher lifetime risk of developing acute pancreatitis. Some patients have another 5 to 6 episodes of pancreatitis. That is around 60 to 70% versus 5 to 10% in multifactorial chylomicronemia, and much lower apolipoprotein B100 concentration. And they are very resistant to treatment. The clinical features, that there's an approach that starts from this. There's a clinical feature phenotype and a clinical feature associated with the recurrent abdominal pain due to acute pancreatitis or malabsorption, hepatosplenomegaly due to malabsorption, and there are many reasons. Eruptive xanthomatosis, lipemia retinalis, fatigue, memory loss, depression, and so on and so forth. This treatment, that if the triglyceride level in a child or adult of more than 1800 for 3 consecutive analysis, naturally first to rule out, we have to rule out the secondary causes, and then clinical assessment, there's abdominal pain, eruptive xanthoma, lipemia retinalis and all that, we have to see that. And then there's a next generation targeted sequencing, which will have a very clear picture of biallelic LPL that we have discussed, and that uh, clinched the diagnosis of monogenic chylomicron. This is one of the most difficult diseases to be treated, and the lifestyle modification is one of the most difficult to adhere with, because this is the only condition, where few conditions where we give lipid lowering therapy, the lipid ingestion in less than 10% of the calorie from the fat. So this is a very important point. And avoidance of alcohol, reduction of intake of high glycemic food intake, and during episodes of acute pancreatitis, there's a complete fasting during first few days with the parenteral fluid support and analgesia. Intravenous insulin for patient with diabetes, plasmapheresis, or plasma exchange is generally not recommended. But at a very for a very high level of triglyceride, then we can go over for a transient plasmapheresis. Our newer investigational treatment like LPL gene therapy, anti-APO, that is anti-PLG3 therapy, anti-PLG3 therapy is enough evanacumab, but evanacumab have a side effect which is dreaded, that is platelet decrease in platelet, is thrombocytopenia. But volemsuran doesn't have that. It's a very costly medication. It's an investigational medication. Now, in a short, this beta lipoproteinemia have a triglyceride and cholesterol are increased due to pathological accumulation of IDL and VLDL with a clinical feature of Palmer and tuberous eruptive xanthomas. The premature coronary artery disease, especially PAD, and most effective, affected individuals are homozygous of ApoE2 isoform, and the treatment includes the control of secondary factors like to control diabetes, paraproteinemia, if one have systemic lupus erythematosus, or poor diet and hypothyroidism, that one has to first treat those conditions. That is the treatment of choice. And finally, monogenic hypotriglyceridemia, that doesn't have any clinical significance, so I'm not going to discuss the details. So now this is one of the very rarest of the rare disorders, that is HDL related disorder. I want to tell a few points regarding HDL. That exact physiological role of HDL is still unknown. As a conventional wisdom and understanding focuses on its contribution to reverse transport of cholesterol from macrophage to liver, but there is a minimal data available in human to suggest that HDL is mechanistically linked to atherosclerosis and cardiovascular outcome. There are many trials, safety inhibitors and all, that shows this is a point. There's a wise pearl which I have gathered. The contention that HDL cholesterol is protective factor for entire population is no longer probably tenable. An insight from epidemiological, there's a clinical pearl, that what I have gathered, that the insight from epidemiological studies indicate that a more complex association between HDL cholesterol and risk of cardiovascular events. There's a CKD infection and premature mortality. There's a J-shaped or a U-shaped curve, that there's a, rather than an inverse relationship, that work best with the level around 50 to 93 milligram per deciliter. And below that and above that, there is a risk of coronary artery disease. There are 3 low LDL related disorders. There's a Tangiers, there's a very, very rare disease, 125 case reports. Lipoprotein A1 deficiency, 60 case reports, and LACT and fish eye disorder, 160 cases. So this, but we have to understand what is this. LACT deficiency is a complete and partial. Complete is there is an involvement of eye, that is cardiomyopathy with kidney involvement, and that is the cause of mortality and morbidity in LCAT. But partial disease, that is not fish eye disease, it only involves a complement. Apolipoprotein A deficiency, that is associated with rare familial amyloidosis after transthyretin, that is causes renal, cardiac, and laryngeal and cutaneous amyloidosis. There's an increased risk of premature CAD with xanthomas, and definitive diagnosis with targeted sequencing of ApoA1 gene. Trangius disease, the diagnosis is based on low plasma HDL, and very rare, that I told previously, there's 110 cases are reported in the literature. Clinical presentations and yellow tonsil, peripheral neuropathy, hepatosplenomegaly, anemia, low platelet, low LDL, moderate triglyceride, premature MI, definitive diagnosis is DNA sequencing. Now, we have to have a management. Management is absolutely symptomatic. And finally, high HDL disorder have a hepatic lipase deficiency and loss of function of mutation in sept and SRB1. That is scavenger receptor protein B1. Hepatic lipase deficiency, around 60 patients are around the world. Another rare monogenic cause due to biallelic loss of function mutation in LIPC gene, which results in a complex dyslipidemia characterized by hypercholesterolemia, hypertriglyceridemia, or some of the patients have increased risk of atherosclerotic cardiovascular disease, which can be managed with statins. Now, what is the care pathway? The care for the patients with rare dyslipidemia would ideally be delivered to a specific and specialized center where apheresis is available if required, and responsibility for care should fall on experienced individual such as certified lipidologist, endocrinologist, cardiologist, gastroenterologist, or primary care physician who has expertise to do that. And there are certain drugs, investigational and in-use drugs, that is lomitapide, that is oral MDTP inhibitor, which is used in homozygous familial hypercholesterolemia. And there are many drugs like mipomersen, that is antisense oligonucleotides, evanicumab, that is anti-ANG23 antibody, and that is anti-ApoC3 antisense oligonucleotide, that is volanesorsen. That is these are the drugs which is really making difference in life of these patients, unfortunate patients. So to cut the long story short, I'm slightly reflective in this slide that development of collaborative registries in conjunction with integration of genomic technology has the potential to deliver real practical benefit to all stakeholders, including doctors and the patients. This benefit include improvement in awareness, management, and access to effective therapy for this condition. The pharmaceutical industry can play a key role in future. Together, complementary and coordinated political, economically, and socioeconomic actions combined with technological advances could mitigate underdiagnosis, misdiagnosis, undertreatment, and ultimately transform health policy for a care of patients with rare lipoprotein disorder. So I end my topic that the disease may be rare, but the hope should not be. Thank you so very much for patient hearing.
Thank you, sir. Thank you for your nice presentation. And as a panelist, Dr. is there and Dr. S.N. Rai sir is there. It's over to Dr. Aloki Gupta. Dr. Aloki Gupta and S.N. Rai sir. First, Dr. Aloki Gupta, and then I will come to Dr. S.N. Rai sir for any comments.
I can't see you all. What is how can I see you all?
So you are audible.
चेहरा दिखाइए हम लोगों का इनको.
अभी चेहरा ही नहीं
मेरे उनको हम लोग का चेहरा दिखाइए.
Just
चेहरा तो देखना बहुत थोड़ी है.
So you are audible. You are audible.
Okay.
आशुतोष जी.
Yes sir.
आशुतोष जी, विनम्र निवेदन है कि मेरा ई साइलेंट है. मैं सिर्फ आलोक हूँ।
Okay, sir.
इसको सुधारिएगा,
मेरा ही साइलेंट है।
स्वीकार कर लीजिए।
कल भी
इसको बताया है।
आज भी निवेदन कर रहा हूँ, मेरा ही साइलेंट।
Okay, sir. Okay, sir.
So Supriyo, you have done a wonderful job. Supriyo means one who is very dear and near, so Priya, and I call him as KB, not the one which you are thinking about, Supriyo. It is Khubsurat Bengali. KB is Khubsurat Bengali. So a difficult topic, but you have justified the topic. I will just give one comment that since the diseases which you have discussed are rare, and the data which you have given for a rare disease is that how much less than 50 per 1 lakh, something like that.
40 to 50 per
So,
lakh.
40
That
to
is a
50 per
threshold
1
one.
lakh population.
Hmm.
So maybe that one may not come across such condition during his practice lifetime. So
Right.
I will just request you that you tell us
Right.
5, 10, 15 major phenotypic points which, by seeing a person phenotype, the signs,
Yeah.
one can suspect that this patient, just like xanthelisma, tendon xanthomas, corneal opacity, something like that, which one come across such phenotypic presentation, one must suspect to order for a lipid profile, and then one can proceed onwards.
True. That is one. That's a very good question. A very good suggestion you have given. That's the average global prevalence that I have shown you. That is around 40 to 50 cases. That is a threshold one. And 7,000 rare disease identified to date. As many as 12 people, or approximately 36 million people in Europe, and perhaps 500 million people worldwide, cumulatively are affected. Okay. So if you see that here in this 25 monogenic dyslipidemia, if we see this slide, if you go with this slide, the LDL, there's hyper beta lipoproteinemia. We have that's the most important here, is the age of onset. If a boy less than 10 years of age with a tendon xanthoma and a feature of morbid obesity or obesity as such. However, there is a possibility dealing with homozygous hyperbeta-lipoproteinemia, familial cholesteremia. So this is one of the points. And if there's LDL cholesterol, when we go with a test, and LDL is go above, if untreated, patient is untreated, if goes above 400 milligram per deciliter, that rather points towards that is homozygous disease. That is, though it is a very rare disease, but you will get in your lifetime, because it is 1 to 2 in 1.5 to 3 lakh population. So in lifetime, you may encounter this patient, one of these patients. That's
लेकिन आंखें वही देखती हैं जो दिमाग सोचता है.
इसीलिए there's a suspicion that I told you, sir. इसीलिए हम लोग को सस्पेक्ट करना पड़ेगा इस पेशेंट्स को कि हम लोग एक बच्चा है इस तरह से. एंड अगर A beta lipoproteinemia, though it is rare, you can encounter as a child, failure to thrive, or usko there are features of retinopathy, multiple fat soluble vitamin
malabsorption
deficiency, malabsorption syndrome, hepatosplenomegaly, और अचानक देखा गया कि LDL level बहुत कम है, so we can easily find it out that probably we are dealing with A beta lipoproteinemia या hypobeta lipoproteinemia. Chylomicron disease, it is rare to get it. Anderson's disease जिसको कहते हैं हम लोग का. PCSK9 and familial combined lipoproteinemia is a good disease to have, because अगर हम लोग को होता है तो we are protected from, just like हम लोग renal glyceria जैसे हुआ था तो हम लोग SGLT निकाल दिए, उसी तरह familial combined hyperlipidemia and PCSK deficiency को हम लोग जब trace out किए, then we had a drug that is known as ANGPLT3 and PCSK9. antibody to PCSK9, क्योंकि PCSK9 बड़ा important role अदा करता है in kidney liver, because what it does it do कि हम लोग जो बार जो LDL and LDL receptor जो internalize होता है, again it comes and it repeats. There are repetition, at least 20 to 25 times repetition. And PCSK, what it does, it just terminates this movement of LDL receptors. तो ये तो एक अच्छा है. Triglyceride के बारे में हम लोग सर बात की है कि recurrent around boy of around 18-19 with a high level around 1800-2000. You also may encounter this monogenic chylomicronemia, but it is very difficult disease to treat. But you know, sir, this patient have a recurrent bout of pancreatitis. This is one of the clinching diagnoses. But if a patient is non-alcoholic and have a recurrent bout of pancreatitis, that might be a case of monogenic chylomicronemia. And whereas Tangiers and low HDL diseases, the cornea is very important sign. Eye signs are very important. Where cloudy cornea in Tangiers, fish-eye disease, LCAT deficiency in apolipoprotein A, all have eye signs. That is the cloudy cornea. So depending upon all this, these are the points which we can, these are the phenotypic important markers which we can easily go, and we can go for the next generation DNA sequencing.
Thank you so much for elaborating all those points. My thing which I wanted to emphasize was that we may not be able to diagnose the subtypes of dyslipidemia, or which is monogenic or not, or we can order that for some specialized center, but at least we can suspect, get the lipid profile done, and if it is deranged, send the patient to a higher center for further genetic study or genetic marker study, and then again manage accordingly. Thank you so much. I think we should,
sir, the point, sir, just I want to emphasize a point. Though these disorders are rare, but they need specific treatment. Suppose you are treating a hypertriglyceridemia patient and triglycerides levels are more than 1000. You have ruled out secondary causes. Patient has recurrent pancreatitis. You have prescribed TG lowering drug. Still TG is not up to the target, and it is very difficult to treat hypertriglyceridemia. So in this subset of the patient, there are rare treatment options: Mukherjee, the gene therapy of LPL, that is called Glybera. These are available in the European market, and these rare conditions can be treated with these agents, and people are treating it. So as a clinician, we should know which are the refractory patient. In which patient we are not getting proper response. Suppose you are prescribing a TG lowering drug and you are getting less than optimal response. So in that case, you should always suspect that you are dealing with something else.
Monogenic form.
So it's the condition where we can go for genetic risk scoring system. So if the bad genes are present, we can diagnose this disorder, and accordingly it can be referred to the lipid clinic, and appropriate treatment can be given. So that's what
Doctor,
my take. Yes, sir.
He is absolutely right, Dr. Ashutosh, but for triglyceride level, it is around 1800 unit, that is more than 10 millimole after the treatment with a 3 consecutive analysis is very important. Otherwise, if you are treating and you get partial response to around 800, 900, means you are not dealing with monogenic disorder. That is very important. That is a very clinching point. You have to understand this very delicate point, that if you are dealing with a patient who is around, whose triglyceride level is around 1800, for 3 consecutive analysis, you have given the treatment and you have get suboptimal therapy response by 800, 700, 800. then you are probably not dealing with monogenic chylomicronemia. You are probably dealing with the polygenic one. And monogenic one, it is absolutely resistant to treatment. Absolute. So you have to go with the LPL, that anti.
That's what I want to say, sir.
Yes,
Sir,
yes,
sir,
yes, yes. That is
sir,
absolutely.
sir, there is one thing. There is one thing called genetic risk. There are
Genetic risk scoring.
which are known to cause increased triglyceride, but there are genes which reduce the triglyceride. Okay, so
Right.
we agree that heterozygous hypertriglyceridemia is associated with the values more than 1000, but in a study it is seen that if you are dealing with triglycerides than 295, and in this subset of patient, if you are going for these rare mutation, the chances of these rare mutation is 2.5 times high. So we are that these disorders are rare, but they are underdiagnosed. Why we need to emphasize upon these treatment? Because there is, in this era, we can give specific treatment. Means we can give that particular deficient gene to the patient and disease can be cured.
True.
And this is very important if those patients are high risk for premature cardiovascular disease also, even the intermediate hypertriglyceridemia.
But triglyceridemia, intermittent one is a risk for cardiovascular, but this chylomicronemia, but they are not. They are basically infamous for GI disturbances.
Yes, sir. What I just want to emphasize is, sir, we should now go away from the older classification to new classification. Let's redefine the boundary. There is nothing called monogenic and polygenic, and there is lots of overlapping between the two. So until unless you suspect it, you are not going to diagnose. That's what the newer classification says.
But
and that is why,
yes, sir. But Dr. Ashutosh, this is the adaptation from, I tell you, this is the adaptation. This is absolutely recent one, and this is the adaptation from rare dyslipidemia, from phenotype to genotype to the management, European Atherosclerotic Society Task Force, which was published in Lancet Diabetes Endocrinology in the January 2020. So it is only 3-month-old publication. So this is the most recent one, European Atherosclerotic Society Task Force, which aims, rather that is what I wanted to discuss. Absolutely, you are true that there is a twilight zone, there is a delicate line, thin line, that we now are going to surpass within 4 or 5 years down the line. And this is a very important topic which I wanted to discuss once you gave me the opportunity, because this is the topic of future, and this is a topic for recent future. So we have to understand that this rare lipoprotein disorders can be treatable, and at least it is manageable.
Thank you, sir.